Good morning. Welcome back to the Broadcast Retirement Network. This is BRN AM for Monday, December 11th, 2023. At our top story today, as suicide rates climb, older men are at greater risk. And joining me now to discuss this and a lot more, Dr. Yeates Conwell is with the University of Rochester School of Medicine and Dentistry. Yeates, it's great to see you. Thanks so much for joining us on the program this morning.
Pleased to be here, Jeffrey. Thank you.
Well, certainly mental health is a big conversation in our society. I think overall we've unfortunately seen suicide rates kind of increase. This research, disturbing as well. As U.S. suicide rates climb, older men are most at risk. I want to get your perspective on this, doctor.
It's actually long been the case that the relative rates across the life course differ quite a lot. And wherever you look around the United States, and even in the greatest part of countries around the world, older people are at higher risk than younger and middle-aged people. And older men are at far higher risk than any other age group. So we've known about that for a long time. What's concerning is the continued change and the increase in that disparity over recent years.
Yeah, I apologize for interrupting you, doctor. I want to ask you any idea as to why. And I think about recent events, the pandemic. Maybe there's some financial strife going on with high inflation costs. Maybe just some people just not happy with their lives at the point that they are in. But any sense from the data as to why this would be the case for men in greater volume compared to women?
Mm-hmm. I think one thing it's really important to know as background for this discussion is that over and over again, it's been shown that older people, both men and women, tend in general to be more satisfied with their lives than are younger and middle-aged people. They tend to be happier. They have other characteristics that they bring with them into older age that make their ability to manage the stressors of later life a little easier. So it's surprising that those suicide rates would be higher in older adults, at least among men, when they are on average a happier bunch. And the real issue there is that there are a lot of different factors that contribute to risk for suicide at all points in the life course. And that it's that there are some people in later life who kind of go off the track. They don't have access to the resources that have made them successful in getting to old age. It's not easy, right?
No,
I first got interested in older adulthood. I'm a geriatric psychiatrist, and so I see a lot of very sick older people. But I got into that business out of an interest in how resilient most older people were. As a young person, I worked as an aide in a rehabilitation hospital. And over again, I saw older people come in with strokes or broken hips and just work hard and get back to where they were with a sense of hope and accomplishment, that their lives were satisfying and they could get back to that place. It's the people who can't for some reason that we're really particularly struck by.
And let's talk about the coping mechanisms, because we're all going through life and we're all going to have nicks and knacks and things are going to be ups and downs in our lives. Have we lost the ability to cope with these things? And maybe we have some people have too high expectations. Like, I think about the way retirement used to be defined. Retirement used to be defined, you're going to be sitting on your rocking chair, playing golf with your grandchildren on your knee, right? And you're going to spend 30 plus years playing golf and traveling. But maybe that's not really the reality. Maybe the expectation is higher than the actual reality.
Well, maybe, again, just to keep in mind that most people do live that reality in older adulthood. They are happy with their lives. So what distinguishes those for whom that's not working? We've learned a lot over the years about what are the things that distinguish that group of older people, and older men in particular, who do take their own lives from those who don't and who continue living successfully in their old age. Those things we refer to as the 5 Ds, and those are depression, disease or physical illness, disability or functional impairment, disconnectedness, so becoming socially isolated, lonely, disconnected from others, and then access to deadly means, and which in the US and in older adults in particular is about firearm use and access. So knowing that these factors are operative, then we got to ask the question, so how do those work together? It's pretty clear everybody, as we age, encounters challenges. So disease is ubiquitous. Functional disability comes with the territory. A great majority of older people in their homes have access to firearms. Lots of reasons people could become disconnected socially through retirement or bereavement, loss of a spouse or friends, sensory loss as disability and functional impairment, and so on. So it really does seem that any one or two of those things, older people in general have the capacity through years and years of experience in managing challenges to do fine with them. Yeah. Not that it's easy, but it's when they accumulate and coalesce in one person at one point in time. You can imagine it as a Venn diagram with the 5 Ds that are all kind of clustered and overlapping. And if you've got one, your risk is a little low, is maybe a little bit higher than the general population. If you've got 2, then it's a little higher still. 3, 4, and 5 with the gun in your bedside table, then that's when we really become worried. So there's something going on in how people can access the resources, older people, that they need. Those very few people who are running off the rails, who need more help and maybe aren't being recognized for it, aren't being allowed to access the things that could mitigate any one of those factors. And if any one changes, then the whole calculus changes. Everybody wants to live successfully. Some people want to die, but there's still always a piece at their core of wanting to live better.
Well, Dr. Conwell, I need to take a very quick break. When we come back, we'll talk more about U.S. suicide and older adults. You're going to want to stay tuned right here on BRN AM. Imagine a new television network that will make you richer, healthier, and in control of your financial future. This network is for the policewoman in Nashville, Tennessee, the baker in Dubuque, Iowa, the teacher in Lexington, Kentucky. We want to make the idea of savings and retirement culturally relevant. But what do you see as a defining issue of the midterms, especially for the smaller businesses? I mean, they are the lifeblood of the American economy. Featuring exclusive interviews, current affairs, and docuseries. 33 years old, you retired early.
The philosophy is money only matters if it helps you live a life that you love.
But you got to start thinking about retirement as soon as you get in.
The Broadcast Retirement Network will drive very high engagement with premium partnerships. So this isn't retirement and savings for your parents or grandparents. This is for all Americans. And we're going to change the way you think about money. Welcome to the next frontier of retirement and savings. This is BRN, the Broadcast Retirement Network. Dr. Conwell, thanks so much for staying with us. Really appreciate you hanging around for segment number 2 this morning.
Sure.
So, I mean, I think we did a great job, and you did a great job kind of unpacking this. And I don't know, I don't want to call it a significant like epidemic, but it's certainly discouraging that, these numbers are on the rise. So I guess it begs the question, what do we do about this? Is there a role? America's an aging society, so there's a lot of strain on local, federal, and state governments to provide resources. But we're all going through our lives. We might have parents, we might have grandparents, we might have aunts and uncles. We're all going through our own lives, and we tend to have that tunnel vision. So, is there an answer, a clear-cut answer, how we can mitigate this rise in suicide deaths, especially among men?
Let me back up to the first comment that you made, that maybe this isn't an epidemic per se. It's close to that, and here's why. We've got this clear pattern present for many, many years that there's an increased risk with age, and for men it just keeps going up and up and up. We also know that, also as you acknowledged, we are in an aging society. Demographic changes, in particular, most recently, we're in the middle of the baby boom cohort, that group of people born between 1946 and 1965 who are now entering older adulthood in great numbers. So you've got a group of people entering that time of life that is the highest risk for suicide. So that's why it is a real public health concern and challenge, because it's not just the older people who are at increased risk. It's that people are moving into that age and bringing with them all of the concerns that you've said before.
And in terms of prevention, I mean, let's talk about the role for government. I mean, if you're advising a policymaker, state, local, federal, I mean, is it a focus on mental health support services? Where do you focus the effort? Because there's a lot of people that are going to be taxing the system, or using the system, I should say. So where do you focus your efforts?
One way to tackle that is to kind of tease apart those 5 Ds and to think about what is the potential approach that addresses each one of those. Because as I said, if there is a source of intolerable pain for the person, which drives their wish to end their life, that's related to any one of those things, and we can reduce that, then that wish to live will emerge again. So the first is depression. So we have good treatments for depression in later life among older people. There are medications. There are a number of different psychotherapies that clearly benefit depression, and also have been shown in initial studies to reduce the risk for suicide on that basis. So first of all is helping older people and their loved ones and caregivers recognize that depression is not normal for older people. And when it's there, it's a signal that something is amiss and we need to get that person help. The great majority of depression care in later life is relatively straightforward and is managed effectively in primary care practices. One of the barriers there, though, is that older people appreciate somewhat greater stigma about acknowledging that they have a mental health problem than younger people do nowadays. And hopefully as they grow older, maybe things will get a little easier. But older people don't talk about their depression or their thoughts of suicide as much as other age groups do. So it's not just recognizing that depression isn't normal that it needs help, but then bringing that out and making it part of normal discourse where appropriate with one's primary care doctor. Great majority of older people in the U.S. have a primary care provider or one of several in a health system. And they are prepared to help address this, but people have to be comfortable talking about it a little bit more. The second is disease. Let me lump the disease and the disability together, the two, second and third Ds. Again, every older person is going to encounter these things, and it's just very important that they have access to the kind of care that enables timely diagnosis of each problem and access to services. Might be pain control, it might be rehabilitative services so that they can maintain independent functioning and be comfortable with increasing physical illness burden. And that's not always the case. Certainly assuring that older people have access to good health care that is given at the right time in the right place for them is critically important. And I think we've made some significant strides in that respect. Slight tangent here, that those strides are, for example, the use of integrated care models wherein mental health services are brought into the office of the primary care provider, because the older person is much less likely to accept a referral outside of that office by their primary care provider to a mental health clinic. They're just not going to go. But if it's brought in to the primary care office, that consultation, that care through a warm handoff to a mental health provider right down the hall, we know that that's helpful in a lot of ways, much more likely to be acceptable. So that's a governmental policy related change that has happened and is going to continue to happen and needs a lot of our enthusiastic support. The fourth, the disconnectedness, is also surprisingly underappreciated for the power that social relationships play in well-being for older people, and indeed for younger and middle-aged people as well. You know, for 10 plus years, the UK has had a minister of loneliness, a cabinet level almost position created out of concern for the increased social isolation that people were experiencing. And social isolation often is associated with loneliness. So, and it has demonstrable impact on all aspects of health, including physical health, like diabetes and blood pressure and so on, but also depression and anxiety and suicidal ideation. So movements are afoot to help develop community-based preventive interventions to reduce social isolation, identify lonely people, and provide them with support. Typically, that comes through the aging services network rather than health systems, but it's becoming increasingly recognized that, again, those relationships between physical health, mental health, social health, all actually need to work together optimally. And then the last is the access to deadly means and the firearm issue here. Again, if an older man has some physical illness and functional disability, but he's got social supports and he's satisfied with his life and he's able to access the healthcare he needs, no problem with the fact that he's got a couple of rifles in a closet and the knowledge and experience to use them because he's been a hunter or he was in the military in Vietnam or Korea. And it's when that older man with that access also becomes then socially isolated and physically ill and functionally impaired and clinically depressed, that access becomes an issue. So there are different discussions going on, and currently in this country, there are very complex discussions about how to balance autonomy, access to firearms by any individual with the safety concerns that are raised when people become nearing that cliff, that edge over which they could fall so easily. So all of that, and that's a public health concern as well, and one that the discussion is ongoing and needs to be sensitive to the particular vulnerability of older men in that regard.
Yeah. Well, Dr. Conwell, I mean, obviously, this is something that we're going to have to keep a very close eye on. Obviously, disconcerting. Hopefully, we can get things trending in the other direction with some of the efforts that you were talking about. Thank you so much for joining us this morning, and we look forward to having you back on the program again very soon.
Thank you. It was a pleasure to be here.
And that wraps up this episode of BRNAM. Have a topic of interest, someone you think we should talk to? Drop us a line, and don't forget, for all the latest curated news and lifestyle, wellness, finance, tech, so much more all in one place, check out today's edition of our daily newsletter, The Morning Pulse. Want to search our archives, check out our latest content? Then visit our website. We're back again tomorrow with another edition of BRNAM. We'll have a very special guest. Until then, I'm Jeff Snyder. Stay safe, keep on saving, and don't forget, roll with the changes. Now is your opportunity to co-create content around any topic on the First Lifestyle and Wellness Network. Reach a global audience through our platform and co-own exclusive branded content. All of our programs are available on demand and also as audio-only podcasts, so you can take us on the go. Broadcast Retirement Network, available anytime, anywhere, and on any device.